Welcome to prostate cancer part 26. Part A, morbidity from medical or surgical castration. The side effect from castration increases duration of treatment. Androgen deprivation with castration may increase the risk of change in the body habits, including gynecomastia, testicular atrophy, loss of muscle mass, decreased lean body weight gain, obesity, and increased subcutaneous fat. Adverse lipid profile, elevated total cholesterol, LDL, triglycerides, HDL, and most lipid change occur within 3 months of castration. Diabetes, insulin-resistant castration can increase fasting insulin level and generate a small increase in glycosylated hemoglobin. The risk increases within 4 months of castration, but does not appear to progressively increase with longer duration of therapy. Cardiovascular disease. Cardiovascular risk might arise from castration-induced hyperlipidemia, insulin resistance, and obesity. The AHA and ACS and AUA diverse states whether the association or an actual cause and effect relation between ADT use and cardiovascular event and mortality remain controversial. Luteinizing hormone agonist and bilateral chirectomy might increase the risk of coronary artery disease, heart attack, prolonged QT interval, and sudden cardiac death and death from cardiovascular causes. The risk of the cardiac mortality from ADT might be highest in men with history of congestive heart failure or MI caused by coronary artery disease. There is limited evidence that orchidectomy and gonadotropin hormone antagonists are favored than luteinizing hormone agonists because they are associated with fewer cardiac events, especially in men with no cardiovascular disease. Anemia. Normocytic anemia, normal MCV, hemoglobin may be declined with the first months after castration and often reach its nadir by 6 months after castration. The anemia can be correlated by either stopping androgen deprivation or administering erythropoietin. Fatigue might be caused by anemia or low testosterone. Osteoporosis. Periodontal disease, no increase in cavities, but there is high risk of plaque, gingival recession, and other indicator of periodontal disease. Sexual dysfunction, decrease libido, erectile dysfunction, infertility, hot flush. Hot flush can be frequently and bothersome. Cognitive deficit recent data suggests that androgen deprivation might cause cognitive deficits such as impaired memory. Long-term castration might reduce the risk death from prostate cancer, but it might increase the risk of death from the other causes such as cardiovascular. The long-term androgen deprivation might not improve overall survival. Testing for side effects in men with receiving androgen deprivation. Cardiovascular risk factor AHA and ACS and AUA adverse recommend periodic follow-up including blood pressure, lipid profile, and blood glucose. Because metabolic changes tend to occur within first 3 months after castration, it is reasonable to conduct the initial evaluation starting 3 to 6 months after castration. The interval of subsequent evaluation is at the discretion of physician. Osteoporosis, the NOF recommendation DEX scan at the time of castration and at least every 2 years thereafter to assess bone mineral density. Anemia, it might be burden to monitor the CBC or blood count for anemia. Hot flush. Hot flush can be caused by luteinizing hormone agonist and gonadotrophin hormone antagonist and bilateral orchidectomy and non-steroidal anti-androgen. All this can lead to hot flushes. Estrogen and progesterone do not cause hot flush. In fact, they are used to prevent hot flushes, preventing hot flushes. Progesterone and megestrol acetate 20 mg per oral BID is one of the most effective regimen and has least side effect. Titrate the dose as necessary. Weight gain is common. Estrogen might cause painful gynecomastia, thrombosis, cardiac side effect. Examples include transdermal estradiol, that's a 0.05 to 0.1 milligram patch, applied twice a week, or diacyl stilbestrol 0.5 milligram per oral QD. Clonidine, a venal vaccine, appear to be more effective. Venal vaccine starting dose is 37.5 milligram per day. If necessary, it can be titrated up to 75 milligram per day. Other serotonin reuptake inhibitors such as paroxetine, sertraline, and fluoxetine have also been used. Vitamin E 800 international unit per oral QD long-term use more than 1 year for more than 400 international units per day may increase the risk of heart failure and mortality. So gabapentin, acupuncture, all this have a relation with this problem. So gynecomastia from androgen deprivation. Gynecomastia is enlargement of the breast. Gynecomastia can be painful. Gynecomastia can be caused by medical castration, surgical castration, anti-androgen, 5-alpha reductase inhibitor, estrogen. But with estrogen is painful. Gynecomastia is the more common with estrogen and anti-androgen than with medical or surgical castration. 5-alpha reductase inhibitor rarely cause gynecomastia. Gynecomastia might resolve after stopping anti-androgen deprivation. However, it's more likely to resolve when the duration of therapy is short, less than 6 months. Evaluation include breast and lymph nodes exam. Classically, classify the breast size by Tanner stage or by measuring the breast. A mammogram biopsy might be indicated in men with family history of breast cancer or focal breast enlargement pain or suspicious breast exam, lump, dimple, or hard. Treatment of benign gynecomastia from androgen deprivation, if possible, stop causative agent. External beam radiation, a single fraction of 12 to 15 gray to the breast before administering anti-androgen or estrogen has been shown to decrease the risk of gynecomastia. The long-term risk of breast external beam radiation are unknown, and some patients still develop gynecomastia. Tamoxifen 10 to 20 milligram per day can reduce breast size and pain. It is most effective when it is started before or soon after gynecomastia development. Breast reduction surgery, liposuction, or excision of tissue reduce breast size and can reduce breast pain. Surgery is often necessary when the gynecomastia is severe, that the Tanner stage more than 3, or long standing more than 1 year. This is the end of part 26C. We will meet again in B.